Hi, everyone. This is Miss Jai. Thank you so much for joining for Ask Miss Jai Live and for joining us early. I'm so excited to be coming to you live from Puerto Rico from the U.S. Conference on HIV and AIDS 2022. We're a little over halfway through the conference, so I'm really excited to give you some information on what we have been learning so far, what I have been learning so far, and hopefully you'll be able to take this information and apply it to the work that you're doing every day. So thank you so much for joining. If you stick around, you'll get a chance to learn some of the things that I've been able to learn so far through the conferences from the U.S. Conference on HIV and AIDS. If you are joining live, go ahead and put a hashtag live in the comments below. If you are joining on the repeat, do a hashtag repeat, and please let me know what you find most interesting. I am going to be showing some of the information visually as well. So for the folks who have joined on Instagram, you won't get a chance to see it. I'll talk about it through this, but you won't be able to see it during the go live. But I will post the actual video that includes those visuals, so you can get a chance to see it on the replay for sure. Like I said before, my name is Miss Jai. I use she, her, and he, him pronouns. I am the host of Ask Miss Jai Live. I'm really excited to be here. My background is in HIV prevention and care. I've spent a little over the last decade doing support services and teachings and trainings on trans and non-binary communities and how we can better support trans and non-binary people in our health services. And I feel really excited to be able to bring this information directly from the U.S. Conference on HIV and AIDS this time round. So Ask Miss Jai Live got started out of a necessity for us to have more information about the health needs for trans and non-binary people. One of the biggest barriers to trans and non-binary people's health are healthcare providers, not knowing how to support trans and non-binary people, not knowing how to be gender affirming in the care that they provide, regardless of its transition affirming care or run-of-the-mill primary care or mental health services. There's a big gap in understanding how to provide gender affirming care. So Ask Miss Jai Live got started as a result of lots of health providers coming and asking questions specific like to me and to my colleagues. And instead of answering those each individually, I decided that we would start Ask Miss Jai Live, so we have an opportunity to spread the message as wide and as far as possible, and give people as many tools as they can use to make sure that their services are gender affirming, that they're meeting the health needs of trans and non-binary people, and especially meeting the health needs of folks at the intersections of race and ethnicity and poverty and mental health services and et cetera, et cetera, et cetera. So thank you again for joining us. I'm going to go a little bit over some of the things that we already know and some of the things that have also been new. So first, I want to thank the TGNC, Transgender Nonconforming Institute, through NMAC and through the U.S. Conference on HIV and AIDS for bringing an institute to us yesterday. This information was provided by Mixed Trinity from Black 5683 LLC and also by AJ Scruggs from Visible Truth 365. So I'm really excited to be sharing it with you today. So the information that I'm showing right now are the trends by age. Let me actually move this overlay. There we go. It's much easier to see now. So these are the trends by age that we're seeing for HIV diagnosis among transgender people in the United States and dependent areas between 2015 and 2019. And what we can see from this information is that for age ranges of 13 to 24, age ranges of 45 to 54, that we are seeing a downward trend. So folks in those age ranges diagnosed with HIV between 2015 and 2019, there were less diagnoses for those age ranges in 2019. So our youngest folks of 13 and 24, and our folks from 45 to 54. However, for our folks from 25 to 34, 35 to 44, and 55 and older, we're seeing upticks in the number of new diagnosis of HIV for those age ranges for transgender folks. And so most important for us to recognize is the 71% increase for folks who are ages 55 and older. So these are folks who are newly diagnosed with HIV, who are identifying as trans or non-binary in surveillance data. And there's a couple of things for us to keep in mind around that. The first is that collection of trans identity is getting better as time is progressing and as more people are understanding the necessity for collecting trans and non-binary information. And so that can be a part and parcel of why we're seeing these upticks. But we're also seeing these upticks in very specific communities. And so the ways that we are providing services to trans and non-binary people are also disproportionate, or are not meeting all of the needs of the individual subcommunities in trans and non-binary community. So we are still seeing the increases in HIV infection, which then means that there's more HIV out and about in our communities. And also, we see that these are likely also still underreported because oftentimes trans people, especially non-binary people, are going to be miscategorized or be miscategorized into a cisgender category. So, and we'll talk a little bit about the history around that and why that has happened. And so I just mentioned a moment ago that there are subcommunities that are disproportionately affected by new diagnoses, or like are not getting the services. And so we can see that in 2019, the most new HIV diagnosis were among transgender people who were Black or African American people. So almost 50% of the folks who were newly diagnosed with HIV in 2019 were Black or African American. And if we think about it, and we think about disproportion, right? So Black and African American people don't make up 50% of the United States population. So we know that that is a disproportionate amount of people from that community who are newly contracting HIV, which means that there is something going on in the way that we're providing services, the way that services are funded, that is not meeting the needs of the community who is at greatest risk for HIV and AIDS. And then the second highest racial and ethnic minority within trans communities who were newly diagnosed with HIV in 2019 were Hispanic and Latino people. At over 30% of those new diagnoses from 2019 were Hispanic or Latino people. So we keep seeing this disproportionate amount within the community of folks who are newly diagnosed with HIV within our trans community as well. Now, when we're breaking out this information, like, it is pretty heartbreaking, right? So we're seeing our communities that are being heavily impacted, or portions of our communities are being heavily impacted. We already know that trans people are at greater risk for HIV because of the way that our society treats trans people, and because of the way that health services are so difficult for us to access as trans people. But I think it's important for us to recognize, for my trans siblings out there, that it's not just trans people who are being impacted or affected, and that as white trans people, we actually are experiencing still privilege within our community, especially around our health, and that it is also our responsibility to uplift and support our Black and brown, trans, and non-binary siblings, because they are folks who are being pushed to the margins around the ability to get their healthcare services met and their healthcare needs met. I also want to share this next one with you, which is trends by gender. So this is one of the first times that I've seen trends by gender, and it's also a comparison between 2015 and 2019. And what we're seeing for new HIV infections for adults and adolescents is that for cisgender men and for cisgender women, we're seeing trends down. So from 2015 to 2019, we are seeing that cisgender men, there was a 10% drop in the number of new diagnoses of HIV infection among cisgender men. We're seeing that there's a 7% drop among cisgender women or cisgender females. But then we're seeing that trans women, there's an increase of 5%, again, disproportionately Black and brown. And we're seeing also an increase for transgender men of 44%, also predominantly Black and brown. And so the thing that I think is important for us to keep in mind around trans men, and like, that is a striking statistic, that there has been an increase from 2015 to 2019 of 44% for new diagnosis of HIV for transgender men in our communities. And I think that's something that it's important to keep in mind around this, like, again, is that historically trans men have been have been told that they are not at risk for HIV. Services have not been dedicated for trans men or trans masculine folks for HIV prevention or for HIV care. And there have been a lot of assumptions made about the sexual behaviors of trans masculine folks and trans men. And as a result, there are not services, but there also has been a lack of testing and a lack of information and data collection. And so there are a lot of assumptions when someone comes in to get services who is AFAB. There have been a lot of assumptions that this person is a cisgender woman. And so there's been miscategorization of transmasculine identified folks in our surveillance data as well. So this is part and parcel the fact that we're collecting this information better, but it's also part and parcel because we are actually taking the time and the energy to develop services and testing and training and HIV care linkage programs and prep programs for trans masculine folks because there is a definite need there and because there is still a lack of information and a lack of services that are supporting trans masculine and folks and trans men. Um, and I'm going to talk a little bit more about the history as well. I think that it's important for us to keep in mind why this research is missing and why this information is missing and why there's suddenly now more information about trans folks in like trans subcommunity, not subcommunities, subpopulations within within our community around HIV care and prevention. And that's because from a historical standpoint, MSM or men who have sex with men was like the first category of research that was taking place for HIV positive people. And this is a slide directly from the presentation by AJ and by Mixed Trinity. So I want to really thank you for visualizing this in a way that is easy for us to understand and to see, because we recognize that when research was taking place around MSM folks, the assumption was that this was cisgender men having sex with cisgender men. And so trans women were not, there wasn't research for around trans women that was taking place during that time. Trans women were often lumped into this same like MSM category. And so then we start seeing research develop around trans women because we recognize that trans women are present in the community and that they're social determinants of health, the ways that they're getting services, the way that they are treated in services, the ways that they interact with the community and explore culturally their relationships and sexuality is different than cisgender men. And so trans women there's research that starts happening around trans women, but then we recognize that like trans men are also part of this trans community. And so we can't just do research around transgender identity and not recognize that trans men also have culturally different experiences, culturally different expectations and engagements around sex and sexuality, and the ways that we are potentially at risk for HIV, the ways that we are at risk for other STIs, and really a lack of information and conversations around reproductive health as well for trans men, and the reality of like gay trans men needing information around pregnancy and fertility, and what is potentially going to look like. So we start seeing more research now, kind of just eking out around trans men's sexual health. And then we're still seeing that there are trans non-binary and gender non-conforming folks who have the littlest amount of research right now. But that littlest amount of research is also showing us that that sub-community or that subpopulation within the trans community, that their experiences are unique and are also different than trans women and or trans feminine folks and trans masculine folks. So I say all of that to say, because we know that this history is present, this is why we are just starting to see our programs and our and funding start to catch up. And I would say that funding hasn't, just fell over. I would say that funding really hasn't even caught up for trans masculine folks or for non-binary or gender non-conforming folks, because you don't see services available really still for specifically for trans masculine folks, or for non-binary or gender non-conforming folks. And I'm a little shaky, so I just need to fix this camera. I want to say hello to everyone who's joined on Instagram. Go ahead and put a hashtag live if you're watching this live on Instagram. I see some folks that I love and I care about. So it's lovely to see you. Thank you for joining. So this is why we're seeing, when we're talking about the history of, oh my gosh, this is gonna fall down again. Let's see if we can do that. Nope. This, nope. Well, it wouldn't be a challenge if I wasn't actually struggling. Hello, hello, Lisa. Lovely to see you. Okay. So I think it's also important for us to keep in mind, and again, thank you to AJ and to Mixed Trinity for putting together this presentation yesterday morning. But I think it's also important to keep in mind that we got here because of a concerted effort to remove transness from the conversation. So what you can't see on Instagram, but what is currently streaming on LinkedIn, YouTube, and Facebook, which I will share on Instagram post, is that in March of 2017, the Department of Health and Human Services quietly removed questions about LGBTQ elders from research, and LGBTQ specific questions were removed from the census. So this would have given us population level data around sexual orientation and gender identity minority folks. And because that was removed, we don't have that population level data. So it's hard for us to say with the research that we do have that this is applicable to all of our communities, because since it's not population level, we're essentially taking like smaller samples and saying, well, this is how this smaller sample is functioning. So when that was taken out in 2017, it makes it really difficult for us to develop services that are going to be effective for everyone. And then in 2018, the Trump administration pushed for the words vulnerable, entitlement, diversity, transgender, fetus, evidence-based, and science-based to be removed from the 2018 budget document. So suddenly we have this like sterilization of our funding of our budget documents. So it becomes harder for us to then develop services and be very specific in those services. Like we couldn't say that we were developing services for transgender communities, or that this funding was earmarked just for transgender communities, because the word transgender couldn't be used. So that is a way that we see this like funding restrictions start to happen. And then the 2020 census did not ask folks about their sexual orientation nor their gender identity. Trans and non-binary folks are documented together based on sex assigned at birth in a lot of our research and our documentation, or our demographic collection. So if you look at a surveillance form, or you look at, I mean, even so, I hail out of Arizona, and even in Arizona, when we look at people living with HIV in Arizona, the numbers of the surveillance data that shows us like how many people of different genders are living with HIV in Arizona, the numbers are so small for the trans community, and partly that's because the way that we're collecting that information is not accurately capturing the fact that trans people are present in our services. And so that becomes a real challenge, because then that research and that information is provided to the federal government, and then funding is provided back to our communities based on that information. And it's funneled through the state, and it's provided to our individual communities based on that information. So if we're not accurately collecting the fact that trans people are present in our communities, then that means that it's harder for us to say that we need funding for trans services, or we need funding specifically for trans-led organizations, or trans-designed organizations, because we can't show in the numbers that trans people are living with HIV in our communities. So surveillance data and the way that we collect it is incredibly important. And then I want to share a little bit from the actually, before I get to syndemic stuff, I want to share a little bit about patient experience. So I really want to shout out and say thank you to the organization Brothers Obtaining and Navigating Dynamic Solidarity, or bonds, and specifically presenters E. Lee and Tyree, for your presentation on transmasculine experience and experiences in healthcare and health settings. And so there's some of the things that really stood out to me is that there are a lot of assumptions that are made by health providers around the needs for that trans masculine and trans men have in health services, as well as the wants and the interactions with trans masculine bodies. So we see this manifest as like assumptions on who our sexual partners are, or who transmasculine sexual partners are, assumptions on whether or not fertility or reproductive health is necessary, or that the person would be interested, gatekeeping of services, so not like sharing that information with patients, with clients, and allowing them to make an informed decision instead of just like making the assumption based on being a provider, and then really not knowing how to interact with transmasculine bodies either. So that could look like either not doing assessments that are affirming to an individual, not knowing how to talk to an individual about their body, not knowing how to have conversations about organs specifically, or making assumptions that folks don't have specific organs, so you're not doing a screening that is effective. So these are all ways that that patients are experiencing providers essentially doing harm and re-traumatizing the body and re-traumatizing the individual around identity as well. There's also this big assumption that in order to be a transmasculine person or be trans in general, that you must hate your body, and you must hate all aspects of your body that are secondary sex characteristics and genitalia and all these other pieces. And we know that that's not the case. Like, we know that we might experience dysphoria, we know that we might experience even body dysmorphia, which is separate from dysphoria, but that being trans does not mean that we have to hate every aspect of our body, and hate every component of our body that might be seen as like one gender or another. And we're seeing a lot of healthcare mistreatment as well. So pretty much like every research study that has been done around trans folks, regardless of the sample size. So we've seen the US Trans Survey, which took place in 2015. There was another survey on mistreatment that had a sample size of about 2,000 people. But pretty much every survey on trans folks has shown that the vast majority of trans people experience some form of mistreatment at the hands of healthcare providers. So that could be misgendering, it could be dead naming, it could be active discrimination and refusal to provide services, it could be challenges with harassment by staff, it could be being outed in a public way in a clinic setting. It could also be things like physical violence, which is reported, verbal violence, and sexual assault. By the hands of healthcare providers. So I think it's important for us to keep in mind that because these things are happening, because these are the narratives that we're seeing in our communities, it is harder for trans folks to build trust with medical providing agencies. And that really, like, getting to a point of even seeing a medical provider takes an awful lot of emotional toll um, and emotional labor just to get to that place because of the ways that we've been treated historically by the medical establishments. Um, and that there's also like a big stigma with getting care as well. So a lot of care is provided through through agencies that provide other services. So if you have an HIV service providing agency and they start doing trans affirming care, then it becomes challenging because we're going to these services and the assumption is that we're getting services because we're HIV positive. So then rumors start about our HIV status in our community, and our community is pretty small. Or the assumption, especially for trans masculine folks, that by going to those services to get care, the assumption is made then that these folks are gay men, whether they be assumed that they're gay cisgender men or gay trans men. And so it actually becomes more difficult to provide services at agencies that are HIV serving agencies because of this additional social stigma that exists around around being gay, around being HIV positive, and how that kind of plays out in in our daily lives as trans people. And so a lot of the programs that have spoken so far about providing trans services and best practice for providing trans service have said that funding needs to go to trans-led organizations. Funding needs to go to trans-led organizations that are doing work in the community specifically for trans people. And there are a couple of funds that have been developed specifically for trans-led organizations. So I'll include that in the notes on the different platforms around this as well. But there is funding that is currently available, especially for smaller organizations. I heard about a fund that's available for organizations that have a budget of 250,000 or less, that is funding specifically trans-led organizations only, and they won't fund organizations that are not trans-led. So there is a push to reinvest into our communities and to take funding and develop funding specifically for trans people by trans people. And now I want to move into the last portion of kind of what I've learned so far, which is around syndemics and specifically monkeypox, COVID, and HIV. So for folks, so this was presented by the Gilead Compass Initiative. So I really appreciated this conversation. It gave us an opportunity to talk about a couple of different ways that we see syndemics take place and how they kind of like play out in our communities. For folks who are unfamiliar, a syndemic is when you have two or more diseases or health problems or two or more epidemics, right, that come together in a population in a substantial way and make a health condition worse for us. So what was discussed was like HIV and COVID, for example. So we have a community that already has like high rates of new HIV infection or a high prevalence meaning a lot of people already living with HIV. And then we have COVID come into that community and into that population. And we see a lot of folks contracting COVID. And now we have two epidemics that are taking place at the same time. And it's they're working together in tandem. They're working together to make everyone's health worse. So that's when a syndemic is taking place. And we started to see that come up with monkeypox as well, because it was hitting these communities that already had other health concerns going on. And so this diagram, which folks again on Instagram can't see, but this diagram on LinkedIn, Facebook, and YouTube shows how syndemic health problems like COVID-19, like HIV, like substance use, like mental health, like STIs, like malnutrition, when multiple of these are taking place at the same time, then we start to see that there are psychosocial and structural burdens that play into this as well, right? So if we're having, if someone is having HIV and COVID-19, they might also be experiencing food insecurity because they're unable to work and pay for food. So they might start to also then experience malnutrition. If we are seeing that folks are experiencing HIV and mental health issues, then they might have a lack of social support and they might be experiencing social isolation. And these things can start to build on each other as well, right? So let's say someone is experiencing mental health issues and HIV, and they have a run-in with law enforcement, then that can lead to incarceration, which then makes the whole situation worse for this person's health. So these are all things that synergize together in order to make someone's health outcomes and health experiences much low. So they worsen someone's health condition. And this was one of the slides from that specific discussion. And I thought what was most interesting about this is that current data suggests that about 40% of people diagnosed with monkeypox in the United States also had HIV. The CDC doesn't know if having HIV increases the likelihood of monkeypox infection once you're exposed. But what we do know is that these things are happening. These things are co-occurring. So if we're thinking about how we get like vaccinations out into our communities, how we work with a limited number of vaccines or a limited number of resources around health, then this tells us that if we are living with HIV, then getting a monkeypox vaccine could be really helpful for us because monkeypox is present in our same community at a much higher rate. And then the CDC also found that 38% of nearly 2,000 people who are diagnosed with monkeypox were diagnosed between May and July were living with HIV. So it's like we just keep seeing this data over and over tell us that this is a community that is highly impacted by monkeypox and by HIV. And we know that if these things are happening at the same time, then a person's health is going to depreciate. It's going to be harder to stay healthy. Um, the other thing I want to share is, the lessons that were learned. So we keep seeing these pandemics, these epidemics, these syndemics come up, and we keep seeing them hit our communities. And so we have to at some point start learning lessons from them, and then saying like, well, how can we apply this to the next one that's coming up? So some of the lessons that were learned from HIV that can be applied to COVID is the fact that like vaccine hesitancy is a reality in our community. So we can't just say like, well, the next time something comes around, we'll roll out a vaccine and if it's available, and the response will be different. No, the response is always the same. Vaccine hesitancy is reality. Medical mistrust and distrust in our communities is a reality. And so we can't keep saying, like, well, this is going to be the way that we're going to approach it, and we're going to expect a different response. We have to do some of the groundwork to have conversations around medical mistrust and distrust, acknowledge the realities of that. And if we know vaccine hesitancy is going to be a thing, then we need to prepare our communities for the what this might look like the next time that something comes out, or how we can work together for communities that are not only vaccine hesitant, but are vaccine opposed. We also know that there's a trickiness with viruses, right? So we have been trying to pin down HIV for decades. We're trying to develop a cure. We're trying to develop treatments that are longer acting, but viruses mutate very quickly. So how can we recognize that this is a reality and recognize that that means we have to move quickly because these things do mutate, as we're seeing with COVID. Um, and that there needs to be more work in communities of color, that Black and brown folks in the United States are disproportionately impacted by every epidemic, and not just infectious disease epidemics. We're seeing it with gun violence, we're seeing it with domestic violence and intimate partner violence, we're seeing it with homicide and violence in general. So like, we know that these communities, and communities that are disenfranchised, communities that are marginalized, communities that have a lack of access to resources, a lack of access to healthcare, and a lack of access to protection and safety are communities that are most vulnerable, and they are going to be harmed more intensely when the next emergency comes around. And then the other piece is that the lessons that have been learned from COVID that can be applied to monkeypox, right? So we know that COVID resulted in a lot of isolation, that resulted in a lot of challenges with our mental health. For trans people specifically, we lose a lot of our community when we're isolated. For a lot of us, our community is solely our trans siblings. And so not being able to meet in person, not being able to spend time with our trans family means that we are experiencing not only isolation because everything is shut down, but we're also experiencing isolation from our basic support structures, in a way that cisgender people don't experience it at the same in the same likelihood. And so I think because of that, it's important for us to recognize that this isolation, because this is happening, we know that in the future, and what can be applied to monkeypox, but also applied to future epidemics that are going to come up, because these things come up as humans, is that isolation hits us as trans and non-binary people in really intense ways. So how can we be prepared for that when the next time we have to isolate or step away from one another, and get resources and services into our communities where we can still connect on an interpersonal level or on a social level and get support with one another. We also know that harm reduction versus abstinence approaches, that harm reduction approaches are going to be very effective in meeting the needs of people where they're at. Abstinence does work for some people. For a lot of people, it does not work, however. So we have to be able to approach this from a standpoint of harm reduction and how can we reduce harm. Um, it- Reduce the most harm. For COVID, a lot of people had to return to work much sooner than they were healthy because they had financial needs that needed to be met because they couldn't be met any other way. And so this might look like things like the development of emergency grant funding or direct payments to trans and non-binary people. We saw we saw a lot of organizations divert funding, and also intermediary funding agencies divert funding to provide direct payments to people who were living with COVID, who were experiencing isolation because of COVID, or were needing to step away from their work because of a positive COVID test, so that they could still have their bills paid, so that they could still afford to buy food, so they could still make sure that they had shelter over their head, because these are the basic needs that we have in order to be healthy. And so how can we expect a community that's being impacted by COVID to remain healthy or to get back to a healthy state if we're not providing them with those foundational pieces that encourage and support healthiness? And then we also saw a lot of community driven messages. We saw massive access to vaccinations, especially during monkeypox. But I will say that a lot of that was happening because of the on the ground strategies that were taking place and the work that was taking place within queer communities in order to make sure that monkeypox vaccines were available. Because we were being told, from the get go, that we weren't going to have access. We were being told, we were being stigmatized as queer folks, because of the way that conversations were happening around who was at risk for monkeypox. And as a result of that, we had cisgender women who were unable to get monkeypox vaccines, who ended up contracting monkeypox and trying to move through this and get services, and were being told by physicians over and over that they didn't have monkeypox. We saw children contract monkeypox, and the conversations that happened as a result of that, because of stigma towards queer folks, especially towards gay men, was that, oh well, if children are contracting monkeypox, it must be because of sexual assault. So we see all this misinformation that's getting out because of the response that was taking place to monkeypox. And so even though we had massive access to vaccinations, that massive access occurred because of the grassroots movement and the push from our community as queer folks saying, like, we are not getting the services we need and this is unacceptable. And then we need to also understand vaccine hesitancy, especially among Black and Brown people, because it goes beyond just I think oftentimes we characterize within the health field and within public health that vaccine hesitancy is because of a uh, just like an obstinance, just because folks are not wanting to get vaccinated because they just don't know any better, or they're unwise, or they're uneducated, or they're vaccine deniers, or they believe in research that isn't real. But the reality is that for a lot of Black and Brown communities, there has been historical mistreatment in medical care. There has been experimentations on Black and Brown bodies that has been condoned and funded by not only the state but the federal government. There has been there have been dosages of things that have been given to Black and Brown people, medications that have been given to Black and Brown people that haven't been, it's not even clear that that was the appropriate dosage. So like these things have been happening. And so for us to turn a blind eye to that, or just to say, oh, well, folks are vaccine hesitant because they just don't know any better, is also erasing that history, and also not taking accountability or ownership over the fact that like this is something that has happened to a community that we have perpetrated against that community. So I think it's important for us to recognize where that is coming from, and then also to get funding and resources into the hands of Black and Brown communities, because they are going to be able tr- to treat their communities the best. I can't go into a community that a Black or Brown community and say, I brought you these vaccines, now let's get them out, because that's not an effective way for us to do that work, and because have that I don't have that same experience. It just doesn't make sense. We know that services are going to be better received, that trust is going to be built better, and that folks' health outcomes are going to be stronger when those services are provided by the community for the community. And yeah, as Michael said, the Tuskegee trials, something that just recently was shared with me. So the Tuskegee syphilis experiment, when folks say Tuskegee, there's oftentimes this thought of like, oh, this is something that's localized, that's taking place. That was a trial, though, that was funded by the federal government. That was research that was done by the federal government in that location. So it wasn't just like this was something that was taking place at a specific university, at a historically Black college and university. This isn't something that's just taking place at that location, as being taken place by these individual physicians, or by folks who have just like kind of gone rogue. This was funded by the US federal government. So there was awareness that this was taking place within a federal institution. And then, yeah, sterilization campaigns, and on and on and on. And I think the fact that I think it's also important for us to keep in mind that these are things that are still happening in our world as well. So if we take a global view as well, we know that there's research that's happening in other countries that is being done by academics, that is being done by researchers who are US based, or who have traveled to other countries because the research restrictions are less intense in those countries. And so we see this happening over and over and over. And really, what it is, it's a devaluing of Black and Brown bodies, a devaluing of Black and Brown experience, and a treating of Black and Brown people as if if they don't have any human value. And it's disgusting, and it's a reality that we need to not only acknowledge, but it also means that we need to take everything that we can, all the resources that we have, and put them into the places where they're going to do the most good. I think that that is all of the pieces. Oh, the other thing is that in lessons learned from HIV, from COVID, for monkeypox, for our next pandemic that is going to come up, because there will be a next pandemic, is to also recognize that we within our organizations, that we do need to have some support for emergency response trainings. So what are we going to do when there is an emergency, and not just like an emergency, like we suddenly have a pandemic, but what are we going to do if there's severe weather? So what are we going to do if there's a hurricane in our area, and we're having clients and patients who are unable to get services or unable to evacuate? What are we going to do in those situations? What are we going to do if I'm from the Southwest, from Arizona? What are we going to do if we have a particularly dry summer and we have folks who are experiencing heat stroke, or if we have folks who are living on the street and they're unable to get into shelter spaces? What are we going to do if there is a just like a violent disruption, if there is a shooting, if there is violence that's being perpetrated in our communities? I think as trans and non-binary people, we experience a lot of violence in just public spaces, and so we have to be prepared for how we're going to support our communities as organizations, and how we're going to respond to emergencies when those emergencies occur. And Michael, you said, if there are any pamphlets or PowerPoints about vaccine hesitancy at the conference, would you bring back materials to share with you? Yeah, so I'll keep an eye out for it. I haven't seen a ton on vaccine hesitancy, but I will be going through the like tabling area tomorrow just to get a better like see what is available. So I'll keep an eye out for vaccine hesitancy stuff specifically. And for folks who are tuning into this, what I find about vaccine hesitancy, I'll be sure to share through social medias as well, whether that's taking a picture of it or if I'm able to find the website or the original pamphlet, sharing that publicly as well. So thank you for that question. I think that because there's so much that we could cover, I mean, this is like a drop in the bucket of what I've learned so far. I'll go ahead and do for next Sunday, I'll do a part 2 to this for the second half of the conference. I'm really excited for some of the things that we're going to be that I'm going to be learning about. I'm learning about, this morning, I got an opportunity to sit in on an institute on thriving in Indigenous resistance. I was able to I'm going to be sitting in on some more work around transmasculine identity, especially for Black and Brown transmasculine folks and trans men. So I think that there's going to be a lot more pieces that can be useful and helpful for us as health providers, and as for my trans fam, for my siblings out there in the community, the reality, or I think there's going to be a lot more pieces that I'm able to bring to you all as well. And also, I'm really excited to be able to help amplify voices and also step aside as a white trans person and provide more platform for Black and Brown trans folks. So I'm really, really excited to be sharing this information. One final thing is I do want to share that Bonds, who I mentioned earlier, they do host a trans men and trans masculinity retreat that will be taking place in November. Please keep a lookout for it in my next newsletter because I'm going to provide a direct link to it so folks can register and enroll. It is open and available to anyone of transmasculine identity. And it looks really amazing. Like it's 5 or 6 days of just like building bonds and leadership. The organization exists to help transmasculine trans men develop leadership skills and network and build community amongst transmasculine people, which is really not available in a lot of areas and a lot of venues. So I'm excited to share that information with you all. If you're not registered or signed up for the newsletter, please go to my website, www.askmissjai.com. Scroll to the bottom and you can sign up for the newsletter. I send out a weekly newsletter every Friday. And in that, I share a gratitude because I am super grateful for everyone who tunes in and shares in this love and what we're building. But I share a gratitude. I share a resource, and I share some updates from askmissjai.com and some of the things that are happening, including like handouts on financial resources and all these other pieces. So please sign up for the newsletter. I'd love to share that information with you all, and that's where I will be sending it out. Much love from Puerto Rico. I can't wait to see you all in a few days. And yeah, I hope you're having a wonderful Sunday and that it is easeful and peaceful. Much love.